And Laura is the Director of Behavioral Health Services at Whitehouse Clinics, and she's been a licensed clinical social worker in the state of Kentucky since 2013 and has provided behavioral health treatment in a variety of settings throughout her career. And she is here to tell you about SBIRT. Go.
All right, I'm going to try to figure out how to share the right screen. So Travis, tell me if you see the, like, when I share it, if you see the actual slideshow.
I got you.
Versus the notes.
You are correct right now. You're good to go.
I see this. You see the slideshow? Okay.
Yep.
Hang on one second. Sorry, give me just 1 second. Okay. You still see the slideshow?
Yes, we do.
Perfect. Okay. Hi, everyone. I'm Laura. As Travis mentioned, I'm the Behavioral Health Director at Whitehouse Clinics. I have been here for 5.5 years at this point. I've been in the director role for 4. And today we're going to talk about, I'm excited to get to share with you all a little bit about screening, brief intervention, and referral to treatment, which is screening for, specifically in this context, we're going to talk about screening for alcohol and other drug use in primary care. So our learning objectives today, we'll talk about, why SBIRT, what's the purpose, why do we do this? I'll share a little bit about the model that we've implemented and some of the barriers and successes that we found. And then we'll talk a little bit just about the skills and supports that are necessary for responding to alcohol and other drug use in primary care. Just a little bit about our clinic. So for those who are not familiar with Whitehouse Clinics, we are what's called a federally qualified health center. We were founded in Jackson County in 1973. And as an FQHC, we are really, our mission is really to provide safety net primary care services to underserved populations. So a lot of community health centers or FQHCs fall into rural health networks, which is where we are. We're considered rural health centers. So really our mission is to provide access to care for people who don't have access from other places. And so it was in that spirit that we really started providing substance use disorder treatment, specifically medication-assisted treatment, about 3.5 years ago at this point. We are a private nonprofit organization. We have a board of directors. We have 8 clinics in 5 counties. We're going to be soon opening an actual brick and mortar building in Lancaster, which we're really excited about. Our annual budget's about $30 million. We've got, we see about 31,000 patients a year, which is incredible just to have the opportunity to talk to so many different people throughout the years. And we offer integrated primary care for both for medical, behavioral health, oral health care, as well as on-site pharmacies. So when we talk about SBIRT, what we are talking about, like I said, is screening, brief intervention, and referral to treatment. And it has been, I'm going to just read this definition from SAMHSA. It's been defined as a comprehensive, integrated public health approach to the delivery of early intervention for individuals with risky alcohol and drug use, and the timely referral to more intensive substance abuse treatment for those who have substance use disorders, So I think it's really important to understand that SBIRT is intended as a public health approach. Like that to me is the most important part of it. So just like we screen your blood glucose levels annually, just like we are checking your blood pressure every time you come into the clinic for a visit, just like we encourage vaccinations and address other public health crises and other public health needs. Problematic alcohol and drug use is a public health issue. And so SBIRT was really created to use healthcare as a platform to be able to identify patients who maybe have high risk patterns of use, but at the very least, just provide health education about alcohol and drug use. And it's also been used for tobacco use and for depression, anxiety, and trauma. But we're going to talk less about that because of the context of this training. So what is SBIRT not? It's not a behavioral health evaluation. So when I first started here, I was like, oh, I can complete the SBIRT steps during a behavioral health evaluation. And our billing people were like, no, that's part of a mental health evaluation. SBIRT is really intended to be completed by the primary care team. And then if a patient gets engaged with behavioral health treatment, that is part of that referral to treatment piece of it. SBIRT is not substance abuse treatment. It is the screening and the motivation building to get a patient to treatment. So we all know in the work that we do that not every patient needs or is ready for a specific intervention. However, SBIRT is a structured, systematic way that enables primary care providers and emergency room physicians, nurses, college health center employees to ask the question and to create a space where patients know that if they need help with alcohol or drug use, this is a place they can come. It also provides that opportunity for education. So why healthcare? Why do we talk about alcohol and drug use in healthcare? And it is because it is a health concern, right? So we know that both alcohol and drug use have short and long-term consequences. One of the things that's interesting when you look at the research that's been done about the effectiveness of SBIRT, there is solid evidence about the effectiveness of all of the stages of SBIRT. So systematic screening, brief intervention / treatment, and referral to more intensive treatment. All of those stages have shown strong effectiveness at strong evidence for effectiveness at making a difference in people's behaviors related to alcohol use. One of the things that with alcohol versus drug use is that, oftentimes, and I think that most everybody on this call knows this, the harm from drug use is much more immediate or short term. It happens quickly and it's often much more noticeable. So oftentimes by the time, a patient discloses their drug use, they are at a point where they need treatment. There's that middle step of brief intervention, of education about if you continue in this pattern, it could be harmful. Oftentimes patients are already at the harmful stage by the time we're aware of the drug use. Alcohol, on the other hand, has continued to really be this less talked about, but just as damaging public health issue for a lot of people. So, just like high blood pressure, just like high blood sugar levels, the harm from alcohol use accumulates over time. And this graphic here is from SBIRT Oregon, which is a really incredible resource if you want great printables, great pocket cards, patient education materials. But it just talks a little bit about what are the risks of unhealthy drinking? What is this going to do to your body over time? It talks about different cancers. It talks about the impact on your immune system, obviously liver damage, pancreatic damage, impaired sensation leading to falls, the cognitive issues that come from long-term alcohol use. And so SBIRT gives us the opportunity in healthcare to say, we're screening you for all of these things. We are, checking we're doing blood work to make sure that your metabolic panel is within the normal limits. And also we want to talk about something else that could create a long-term problem for your health if it continues at an unhealthy level. The other thing that was really interesting as I prepared for this presentation is, when we talk about alcohol use and why we need to talk about this in healthcare, so I'll explain what this graph is, but it's looking at the comparison in alcohol use trends from some survey that was done in 2018 and published in 2019 versus a survey that was done in 2020. And the data from 2020, if you are a research expert, is not as clean of data as we would often like to see, but it's emerging and I think it's reflective of trends. And so it is a peer-reviewed study, but there will be more data that comes out over time. But what I wanted to point out in this, that top line, the navy blue line, is the percent of patients or survey respondents who reported binge drinking within the previous 30 days. So in 2018, that was 26% of people. But in this 6-week period in 2020, which was from March to June 2020, so during that initial lockdown and shutdown that we all went through, it was up to 34% of people had reported binge drinking within the past 30 days, and 7% of people reported severe binge drinking. we went from the number of drinks total that were consumed over a 30-day period. In 2018, that average was 12. In 2020, the average was 26.8. So that's at least one drink a day. And then the number of days that alcohol was consumed went from about 4 days or 5 days to about 12 days. And where that really matters is that, this quote, which is from an article that's cited at the end, where they looked at the trends following other periods of economic and psychological distress. So, the prolonged stress that everyone's been under for, due to the pandemic, they looked at other times where there had been similar circumstances. And so natural disasters, disease outbreaks, the September 11th attacks. And what they saw was pretty consistently 2 to 3 years after the initial event and the initial spike in alcohol use, there was an increase in rates of alcohol misuse and dependence 2 to 3 years later. So we're now 2 years past the initial shutdown from COVID, and we saw the impact in these numbers of what that had, the impact that had on people's alcohol use patterns. And so what we will likely see in healthcare now, if we start asking the right questions, is that people are still using alcohol and drugs at an unhealthy rate, and we want to be able to intervene early. So, what happened? Hold on one second. That was weird. Okay. So again, why do we talk about this? So again, this Whitehouse Clinics is a primary care organization. So we're not a hospital, we're not an inpatient setting, but we do provide primary care services. And so, when we started talking about implementing SBIRT here in primary care, we really wanted to talk about why, why do we do this in primary care? There's a lot of conceptions about what happens when you start asking these questions to patients. A lot of something that I heard frequently when we started talking about this was that they're not going to be truthful. Like they're not going to tell us the truth, right? Or worse than that, that they would be offended, that patients would feel, especially culturally here, that they would feel like their doctor was out of line asking them about alcohol or drug use. And so, this data is from 2006. It's from Miller's study in 2006, looking at alcohol and alcoholism. And I pulled this again from the SBIRT Oregon website and their training materials. And it's a survey that they had given to patient attitudes in 2006. And one of what they asked were, if my doctor asked me how much I would drink, I would give an honest answer. 92% of patients agreed with that. If my drinking is affecting my health, my doctor should advise me to cut down on alcohol, 96%. As part of my medical care, my doctor should feel free to ask me how much alcohol I drink, 93%. And so when I shared this with our medical teams, they were, surprised that was the data was, but I will tell you, that's what our experience has been. Our patients, I think as we've implemented SBIRT, there's not been a time where a patient has denied. I won't say there's not been a time. I have not heard of many times where a patient has adamantly denied that they are drinking alcohol or using drugs in a harmful way, where the provider's like, I know that's not true. I think particularly with alcohol use, people tend to be honest about it. And then it gives you an opportunity for intervention. The other misconception often is that I would be annoyed if my doctor asked me how much alcohol I would drink, and patients overwhelmingly disagreed with that when they were asked this question in 2006, and also about embarrassment. And what I will say, what we have found, we've had very little pushback from patients. They're not upset that we're asking me these questions. And I think when you frame it in the context of SBIRT, which is, this is a healthcare intervention. This is a health behavior that we want to talk to you about the same way we talk about your diet and the same way we talk about patterns of exercise. Patients are receptive to that. They don't get super upset by it. They don't get offended by it. So I'm gonna drink water. When we look at SBIRT as an intervention, a lot of the data that I incorporated into this presentation is actually from it's all like SAMHSA has done a lot of work around SBIRT and SBIRT implementation. And so you can just go to their website and find all of this, but this is from one white paper that kind of synthesized all of the literature. So that white paper is cited at the end. If you go to that resource, you'll find all of the background literature that all of this came from. So, when we look at effectiveness of SBIRT as an intervention, the U.S. Preventative Services Task Force recommends a comprehensive SBIRT as an effective intervention, specifically, like I mentioned, for alcohol use. what they found is that systematically screening patients opens the door for just a clear conversation about what patients are already doing. And then that brief intervention and brief treatment, which we'll talk about what that means in a few minutes, is particularly effective with alcohol. The number of times that I've, sat with somebody who, had just turned 21 or 22 and is going out a whole bunch and partying with their friends. And I'm able to say, that's great and have fun and do you, but at the same time, know that if you continue to drink at the level that you're drinking, it's going to cause some problems later on down the line. That, I don't know how much of a difference it's made for those 21 and 22-year-olds, but they're receptive to it at least. So they found that, even that just the education and the brief intervention part is really helpful. And when we talk about drug use, again, the screening is helpful in identifying patients who are using alcohol, has been shown to have strong evidence of effectiveness with patients who are engaging in drug use. And the referral to treatment has also been very effective. And I think that's because, again, like I mentioned before, by the time we are aware in primary care of a patient's drug use, we do have some opportunity, particularly with marijuana or with, early experimentation with drugs, to communicate with patients, here's the harm that could come from it. Oftentimes, though, we're seeing patients who really need to be in treatment, whether it's outpatient or inpatient treatment, because of where they are with their current use. The impact of the intervention, asking these questions in primary care as part of just a general preventative care screening, really, we have found it helps to normalize the conversation for patients. It takes it away from being a moral issue and makes it a healthcare issue. So again, when you frame it the same way that we ask about your diet, your exercise, whether they're smoking in the home, all of these things, it takes the moral piece of it out of it, and it just makes it a healthcare issue. I'm just going to ask about some behaviors. It gives the opportunity for early education before there's significant damage. So again, I think of this with young adults who are in college and who are kind of playing around with what they want to do. It gives you an opportunity to have a conversation about, just think about what the impacts may be. And particularly, our patient population, which I think is true for everyone who's on this call, have a lot of substance abuse in their family. There's been a lot of addiction in a lot of these families. And so it gives the opportunity to, talk with folks about how, it may be fine for their friends to go out and drink these things. It may be fine for, their friends to, occasionally use drugs, but because of the neural pathways that are genetically in your brain, that may not be fine for you, and it may be much more dangerous for you. So it just opens that opportunity for early education. The other thing that the research has found is that repeated screenings are more effective. And I'm going to borrow a story from Cherokee Health Systems in Tennessee for this, but I think it just really captures why repeated screenings are really effective for engaging patients in addressing this behavior. They share this story in their integrated primary care and addiction training. And it wasn't shared in the context of talking about SBIRT as a model, but it speaks to why it matters. They had a gentleman who would come in to see his primary care provider. And every time he came in, he was wearing a trench coat with 2 bottles of beer in each pocket on each side. And so they had some way of systematically just asking about alcohol and drug use. And he was always like, nope, not a problem. And the behavioral health provider was like, are you sure? Because we've seen this several times. He's like, nope, I'm good. I've got it under control. And this went on for years. I mean, they asked him for years. And he was never interested in making any changes to that behavior. However, there came a point where I think something had happened, something catastrophic had happened. I think there were financial issues, there were relationship issues, all the things that we see that bring a person, that tip the scales of change. And when that happened, he came in and he said, okay, I'm ready to get help. And because they had repeatedly in an accepting, a non-judgmental, a very normalized way, continued to bring up this conversation with him, he knew it was a place where when he was ready to get help, he could come there and he could get help. I will say that we have definitely seen that with our patient population here. And that's what we really try to communicate to them. It's not my job to try to convince you to do what I think that you should do. That's not my job. My job is to just offer you the options and help you think through what it's making mindful choices. You know, I used to do work with 7 challenges, and, you know, they would talk about with kids. And when we were talking about addiction with teenagers, you know, we're just trying to help them make mindful choices, to think about the pros and cons of this behavior. And so SBIRT really gives you the mechanism through which to do that. So when we talk about our process here, which I'll kind of talk about as we talk about what SBIRT means, and I will share a little bit about how we roll this out here at the clinic or in our clinics. So again, we started talking about this in 2019. I had providers asking, you know, when are we going to start universally screening for alcohol use? When are we going to put this process in play? Obviously, there's a lot of push from federal entities to implement SBIRT in a systematic way. So we started talking about it 3 years ago. It was not until March of this year that we were able to actually implement this process. You know, there were a lot of barriers that delayed the implementation, largest of which being that 20 and 21 were in between those 2 years. And, you know, it was one of those things. And I think that for people in administration, I think that this is just an important conversation to have, because, you know, during the pandemic, there were so many rapid changes in healthcare. Every day was different. I don't have to say that to you all. You all know that. But we really had to weigh the change capacity of our healthcare workforce during the pandemic. So if you start, you know, in the middle of implementing telehealth, in the middle of moving every sick visit outdoors because of concerns about infection, you know, and every day being different as to whether I can return to work if I was exposed to, you know, my spouse who has COVID, or on and on, all the things that changed. You know, when you talk about trying to roll out a new screening or a new universal process, you really have to measure what the capacity is of the workforce to take that in. And for a couple of years, we couldn't do it. You know, we were maybe informally doing this, but we couldn't begin truly universal screening until we had come back to a point of stability. The other part that we really, that is really important when you think about what it takes to implement universal screening, is that you've got to have the care team available to offer the right intervention when needed. So it doesn't work, or I would say it probably doesn't work, to you know, ask patients about high-risk alcohol and drug use. Patients disclose high-risk alcohol and drug use, and then you say, okay, well, call this place and they'll get you in for treatment. That's not going to happen. You know, you have to have the care team there, or at least have those partnerships with community members and the capacity to really like get the patient where they need to go when they need to be there. So for us, that means, you know, we've got on-demand behavioral health access. So we have behavioral health consultants who maintain open access on their books to be able to intervene if a patient discloses, you know, risky use and really needs some education or some motivation toward treatment. But we've also got a strong team of peer support specialists, and without them, I don't know how this process would work. So those are some things that I think are important to consider when you think about what it takes to implement SBIRT. The thing that really tipped the scales toward action for our organization, though, were quality improvement metrics. So anybody who has been around behavioral health for any period of time knows that it's like nigh on to impossible to find standardized, nationally or state benchmarked performance metrics for behavioral health conditions. It's just really hard to find them. So we have adopted some HEDIS measures, and 2 of the measures that we adopted were the alcohol and other drug use treatment, alcohol and other drug treatment initiation and engagement measures. So we started looking at, once we have identified that a patient has an alcohol or drug use concern, how do they begin some form of treatment within the next 14 days? And do they then, I think, come to 2 additional visits within the next 30 days? And as we started looking at this, what we found were that for our patients with opioid use disorder, we were doing great. Like, I think like 80% of them were initiating treatment within 2 weeks. And, you know, over 50% were still engaged in at least 2 visits within 30 days of that initial engagement. Which for this population is a pretty big deal. However, what we saw was that our patients who were struggling with alcohol use, we were not doing great with. You know, it was almost like there was no, we may have identified that it was a problem, but you could almost, when I did chart reviews and I read the provider notes, you could almost feel the frustration and the hopelessness of the provider Because it's like, okay, now I know that this is an issue, but what am I supposed to do about it? How do I get the patient where they need to go? So the providers actually began, as we looked at these metrics, they actually began asking for a standardized screening and intervention process, at which point I was like, Christmas has come, we have a plan. So that was when, March of this year was really when that scale tipped and we really started universally implementing this process. So what is SBIRT? So characteristic wise, SBIRT is brief. It is usually 5 to 10 minutes of education. So that's not more time than you're going to spend on educating a patient about their other health conditions, other health behaviors. If you're going to do a brief treatment with a patient, so, some brief follow-up visits to kind of check in on goals that they set, you're looking at maybe 5 to 12 sessions, 15 to 30 minutes a piece. And that would be done by a behavioral health person. That's not done by the primary care provider. The screening is universal. So we don't discriminate. We don't screen some people more than other people. We may rescreen if there was a concern, but for our general population, we're doing once a year, we're screening them. And we're targeting one or more specific behaviors related to risky alcohol and drug use. So, we're looking at, okay, you're drinking 6 beers now a day. Can we consider cutting back to 4 a day? That's the specific behavior. And then the next time I talk to that patient, I'm going to ask them specifically, how did that go? Again, it's a public health, non-substance use treatment setting screening. So it's preventative care, which is what we do in primary care. And then it's comprehensive. So we're not just screening with no follow-up, we're screening, and then there's a plan for follow-up on a positive screen. So on the next screen, I'm going to show you all actually a training video from SBIRT Oregon. It's about 3.5 minutes long. So Travis, if there are issues, like tell me to stop it and I'll figure it out and start it over. So hold on one second. Let me get it to it. I am going to share sounds and then I'm going to play it.
Hi, how may I help you?
Hi, I'm Alex. I have an appointment with Dr. Winkle today.
Okay, let me check. Looks like you do have an appointment today, and you're due for your annual screening form. This is a form we give all of our patients once a year, and if you have any questions, please ask Dr. Winkle.
Okay.
Oh, oops.
The annual, or brief screen, is given to all adult primary care patients once per year. Patients who score positive qualify for a full screen.
Alex? Hi, my name is LaTanya. How are you doing?
Fine, thank you.
Good. I'll take the yellow folder. Now I'll take you back to your room.
Okay.
Alex, if you could please have a seat on the exam table.
All right.
Thank you.
The medical assistant quickly scans the brief screen and gives a full screen to patients who score positive.
Here's an additional form for you to fill out. Please give it to Dr. Winkle when you finish.
Okay.
Thank you.
The full screen measures severity of substance use to indicate if a brief intervention or referral to treatment is needed. Hey, Alex.
How are you?
Good. Good to see you.
Good to see you.
So, you're here today to follow up on the migraines, right?
Correct.
So, in the last 6 weeks, how have those gone for you?
I'm still getting them.
As part of the visit, the primary care clinician addresses the full screen. So, Alex, we have you on a new medication plan for the migraines.
Uh-huh.
Do you have any questions about it?
Nope.
Great. So, before you leave here today, I saw that you took the time to fill out one of our alcohol screening forms.
Mm-hmm.
Thanks for doing that.
Yeah.
Is it okay if I look at it with you?
Sure.
Okay, let's have a look. All right, here. So, answers on the full screen are totaled, and a category of use is circled at the bottom. Okay, so when I total your score, based on your answers here, it looks like you score into a zone of use we call risky.
Really? Because I don't drink that much, and it's not a problem.
So your drinking doesn't seem like a problem to you?
No.
Okay. Well, I tell you what, if you're open to it, a colleague of mine here is great at talking with patients who typically score into this category to help them decide if they want to do anything about their drinking or not. That way, I'm just making sure I'm providing you with our best care we can. If it's okay with you, would you be open to me introducing him to you?
Sure.
Great. Well, I'll be back in a minute with Demo.
All right.
Thanks. The primary care clinician performs a warm handoff to the behavioral health specialist. Alex, this is Demo.
Hey, Alex.
Nice to meet you.
And Demo, Alex filled out one of the alcohol screening forms and said it was okay if you came in and talked about it with him.
Is that okay with you?
That'd be fine.
Great. I'll give this to you.
Thank you.
And Alex, I'll see you next time.
All right.
Great. Thanks.
Thanks.
Alex, we haven't met before. I'm actually one of the healthcare professionals here at the clinic. Do you mind if we review the forms that you filled out?
No, that'd be fine.
Okay. Can you tell me a little bit about your drinking?
Well, I like to have a few drinks on Fridays.
Uh-huh. And what do you drink?
The behavioral health specialist performs the brief intervention.
Fridays and sometimes Saturdays.
Under the medical home model of primary care, the receptionist, medical assistant, primary care clinician, and behavioral health specialist all carry out the SBIRT clinic workflow.
All right, so that is just one example. And like I said, that's from the SBIRT Oregon website. And we'll talk a little bit about that later, about some of the resources that they have. But, you know, I always, I chuckle when I listen to that, because I'm like, when you think of from a motivational interviewing perspective, who heard the reflection? So I hear that you don't think that your drinking is a problem, you know, all of those things that, and I think once we can, you know, as behavioral health professionals, we have an opportunity to help our friends in the medical field to feel more comfortable with asking those questions. So I'm going to go through, and I hope that that gave you kind of an overview of what the SBIRT screening process looks like. But I will, I'm going to go through each of the steps with you. So, you know, they started out with a standardized screening. You heard the receptionist say, you know, once a year we update these forms for all of our patients. So, so it requires the use, in order to build the SBIRT code, you've got to use a standardized screening tool. The most commonly used ones, but there certainly are other ones to use, are the audit for alcohol use, the DAST for drug use, and then the CRAFT for adolescents. And we, and I'll show you this on the next slide, but when we do this, we use just the kind of brief questions to start with. So it's the NIDA quick screen questions. And then a positive response to the NIDA quick screen for alcohol would prompt the use of the DAST, and a positive response for the NIDA quick screen for drug use, the audit. A positive response for the NIDA quick screen for drug use would prompt you to go to the DAST. So I am hopeful that you guys can see this. It might be super small, so I'll kind of walk through what this is. But this is basically our workflow and our decision-making process. So we have a template integrated into our EHR that asks the primary care provider can pull up that template, and they can ask, and it's interesting because our medical providers felt pretty strongly about this. The medical provider is who asks the questions, not the medical assistant, which is a little different than in the video that you just saw. But the reason we said that is that, you know, oftentimes it's the primary care provider who has the relationship with the patient, where the patient may be more honest with them. And we don't give them the form to fill out. We ask the questions verbally. Because what I found, even with depression screening, is when I ask the questions verbally, I get a very different response often. But the first question is, how many times in the past year have you had 3 or more drinks in a day? And the patient can say, you know, none, which you would mark none, or 1 or more. And again, if they mark 1 or more, then that's going to prompt to the provider to continue on with the audit screening for alcohol use. The second question is, how many times in the past year have you used a recreational drug or used a prescription medication for non-medical reasons? So if a patient answers in the affirmative for that, it's going to prompt the provider to go on to the DAST. And, you know, sometimes I think for the most part, our primary care providers complete the audit and the DAST with the patient. Sometimes if the primary care provider is slammed, they may be like, okay, you know, just with that affirmative answer on one of those 2, I've got another member of our team who I'd like to come in and go through more of this information with you, at which point they might bring in the behavioral health consultant to go through the audit and the DAST. But when you complete the audit or the DAST, all of them have zones on them of use, and so, or of levels of risk. So And whatever the zone is on the screening tool is going to kind of help guide what your intervention is from there. So if a patient is zone 1 on the audit, none or infrequent use of cannabis on the DAST, they're considered low risk. And so at that point, the medical provider is just going to provide like less than 5 minutes, maybe 1 or 2 minutes of brief education about those high risk drinking limits and risks of excessive alcohol use. And just basically say, good job, keep going. If, using more than this could create a problem for you. So good job, keep doing what you're doing. If a patient scores in zone 2 on the audit or the low use on the DAST, we consider that to be like really borderline risky. So for those patients, behavioral health does not necessarily become involved in the intervention at that point. Or even peer support typically. This is still mostly a conversation with the provider who's just going to do some brief intervention with the patient to talk about, if you were to continue in this pattern, this is what could happen. And really asking the patient, are you happy with the amount that you're drinking or the amount that you're using? Is it something that you'd be interested in making changes to? If the patient says, yeah, then great. That's when the behavioral health provider or peer support would be brought in. The patient may be like, no, I'm cool. What you've told me is good enough. I'm going to keep it at this level. And we go, then we just mark it complete and move on and rescreen, at the next year, or if something additional comes up. Once we get into zone 3 or 4, or moderate or severe on the DAST, that's when we really are involving more of the care team. So that green zone, that's just the provider saying, good job. The yellow zone is some brief just education to the patient, a little bit of intervention about, hey, probably we need to slow back a little bit or don't keep going in this direction. Once you get into the red, that's really where there's more treatment involved, and it can be brief treatment. So brief treatment could be the behavioral health provider coming in, and we use telehealth a lot for this. So it may be that the behavioral health provider is in another clinic and we've got an iPad that the patient is talking to the provider through. But it's just asking the patient, about the effects of alcohol or drug use on their life at that point. And, I've seen on the DAST that you marked these things, or, that the audit that somebody in your family has encouraged you to cut back. Tell me a little bit more about that. What's that like for you? Is it something that you've thought about maybe cutting back? And if the patient says, yeah, then you continue to use those motivational interviewing techniques to help them set a goal for themselves that's realistic. And it can just, oftentimes at this stage, people are not like, I'm going to quit, but they might be willing to cut back or set some parameters around it so that if they are using, they're doing so more safely. This would be a time where you definitely want to have some kind of follow-up plan for the patient. So that follow-up could be, if the behavioral health provider talks to the patient, the follow-up could be come back, do you care to come back in a week? And, you said you were going to have this goal of cutting down from 6 beers a day to 4. Would you care to come back next week, or can I at least call you and just see how that's going? And then the behavioral health provider would continue to follow up with them. Patients at this zone also really benefit from peer support. So our providers are great about bringing peer support into these conversations. And what these typically go like is the peer support comes in and just, says like, it sounds like you guys talked about this as maybe part of an issue. Here's a little bit of what my role is here. I've been, I'm somebody who is in recovery. And so I've kind of seen how bad it can get. And I'd love to just offer some support to you. And so, the peer support often from that point will be the ones that will call the patient just to follow up and see how they're doing. There's a handful of patients that our peer support here in Berea calls weekly, even though they're not in treatment, but just to kind of check in and see. And what she said is that they have started to call her too, to say like, I really want to go do this, but I know that that's not in line with what I want to do. And so they've started to work from that perspective too. And then the highest level is really where you are referring a patient to treatment. And, it's potential that in that like red zone, the zone 3, patients may be appropriate for medication assisted treatment, or they may benefit from inpatient treatment, just depending on their circumstances. Level 4, typically a patient is going to need some type of treatment, whether it's inpatient or outpatient with MAT. But it's a pretty clear discussion about here's the severity and the dangers of use, and really trying to build motivation to engage in targeted specialty treatment. I mentioned this before when we talk about the education that we provide to patients who are in that green zone, the zone 1, low risk or no use, we're just talking about like, great, stick with it. And, on this graphic, this is from SBIRT, Oregon. This triangle is helpful to understand, especially if, sometimes there's a perception that it's the same with suicidality. Once we start asking the question, the answer is going to be yes every time. And like, we're going to end up spending 6 hours with every patient who we ask these questions to, trying to find treatment for them. Well, the reality is statistically, like 78% of patients are in that green zone, 9% are in that yellow zone. Then you've got 8% where they need to at least talk to behavioral health soon, if not that day. And then you've got 3 to 5% up at the very top who actually need to get into treatment that day. So sometimes just having that perspective is helpful to, and to normalize to patients too, this is kind of where you are in that. I really like the low risk drinking limits. It's interesting because one of our physicians was in here when we started talking to it, and I have this pocket card hanging in my office, and she said, but that was medical school. And I was like, well, it doesn't mean it was healthy. And if you continued with that past medical school, especially during a pandemic, it could be problematic for you. So, for a lot of patients, I have found that just having these numbers of what constitutes low risk and high risk drinking is helpful to them, because they can kind of frame it up a little bit. I can still drink, it doesn't mean I can't ever have a drink, but here's where it would start to cause a problem. And then you're going to talk about, the primary care provider would also talk about just some of the health risks of continuing, or if they were to drink more. When you get into that zone 2, that yellow zone where you're going to do a brief intervention, again, this is completed by the primary care provider, and it's a 5 to 15 minute conversation max. It's what you saw the primary care provider do in the video, where he asked permission to discuss the screening results, explaining that your role as their physician or their PA or their nurse practitioner, their healthcare provider in that setting, is not to tell them what to do. It is just to provide some information. I'm concerned about this because of, this is what you're reporting. And what I know is that if continuing in that can have these effects down the line. And, you ask the patient, how do you feel about that? And if they're ready to make changes, then that's what prompts further on down the line. But even just those, like having that conversation once a year with a patient can really help build the motivation for behavior change for the patient, or at the very least, help the patient know that if they became concerned at some point, and it felt like they needed help, you're a safe place to ask that. We talk about brief treatment. So this is where it's more targeted toward behavior change. So the brief intervention is still more universal, just offering some universal support or universal education and the opportunity for behavior change. Brief treatment is, you're going to express more concern and say, I'd really like to have another member of my team come in. And that, the behavioral health professional or the peer support's goal in that, within the scope of their role, is to help enhance the patient's motivation to cut back and abstain. So all the motivational interviewing things come into play here. It also talks about, a lot of these conversations have to do with identifying barriers to sobriety for patients, and what additional supports they might need. It can be 15 to 30 minute conversation, one session, or a lot of sessions. But, not like it's like 5 to 12 is the average. But definitely you want to have some kind of plan for how to follow up with the patient after that. Then once you get into the highest level of risk, again, it's only 3 to 4, or that triangle had 5% of patients in screen and primary care will actually need a referral to specialty treatments. So that's just really important because, we had a situation here in Berea a couple of weeks ago where a patient was in MAT. This wasn't the result of an SBIRT screening, but she was kind of going off the rails and really needed to go to detox for alcohol use. And it was 4 hours that day of trying to find a treatment setting, get her admitted, all of the different things. So when that happens, it is stressful and it is a lot of work for the care team. But that does not happen that often. Really, again, this is a public health approach. It's really trying to target people who may not realize the path that they're on, and offer some education and opportunity to make changes. You know, when we talk about referring to treatment, successful referrals are absolutely dependent on strong care linkages. So our peer support specialists are amazing. They will follow that patient, not physically follow them to treatment, but if they could, they would. You know, with this patient the other day, she wanted to go outside and have a cigarette, and our peer support specialist was like, great, let's go sit outside together, because I don't trust that if I let you leave, that you're going to come back. You know, you really want to have a strong process for tracking that referral to specialty care, for getting releases of information. That can be really complicated when you get into 42 CFR and HIPAA, and trying to make sure that you can share information. And then knowing that you have a strong, what we call enabling services here, but case management component that can help remove the barriers, like whatever would get in the way of getting that patient into treatment, like get it out of the way. Right. So, you know, knowing what resources you need, making it available now, having a plan for transportation, knowing what partners you'll call on is really important. And that's going to be different for every community. Here, I think I talked about this a little bit, but just, you know, we use a native template in our EHR. You know, we just develop a plan based on the screening results, and then the primary care provider documents on the SBIRT template, which then allows us to pull data from it, which is also helpful. Something that I haven't talked a lot about, and there's a lot of, on the SAMHSA website, there's a whole section on billing and coding, but you can bill for SBIRT services in primary care, and they're time-based. So it's like 5 to 15 minutes and then 15 to 30 minutes. And there's parameters around what you can bill, but there is a reimbursement structure for it. So knowing that can often help support the additional care team members and the additional work that it takes to get this into play. So just a couple of stories from what we have seen here. You know, as I said, we started this in March of 2022, and through the end of June, which is the last time I reported on this at our quality improvement meeting, we had screened 4,300 and some change patients through the SBIRT model. Vast majority are negative, consistent with what is seen in the research, but 233 did screen positive and report concerning patterns of alcohol or drug use. And at that time, we're able to then be offered at least education from the primary care provider or some kind of appropriate treatment. The really interesting thing is that only 45 out of those 4,300 patients actually declined to answer the questions. So the conception that patients won't want to answer, that they'll be offended, has not shown to be true for us. You know, the other thing that we have found is that asking these questions really allows us to start building a support network for patients. So again, if patients are in that red or maroon, like zone 3 or zone 4 level, our peer support is like automatically in there. And we offer a 24-hour recovery support line. There's also other lines that are available 24 hours as well. So if you don't have one internally, there are other resources. And the peer support will at the very least, you know, introduce themselves. Here's my card, you know, here's this resource. If you feel like you need to talk at some point, there's someone here who can talk to you. And then for patients who say it's okay, you know, the peer support will usually ask, you know, it would be okay if I checked in with you in about a week. And the patients rarely disagree with that. And I think the feedback that we've gotten is that it's been really helpful. And a lot of those patients have begun to start calling on their own when they are having a difficult day or are tempted to go back into patterns that they know are not healthy. The other thing that has been interesting, there have been some stories about just the ripple effect for families. So, you know, I may be asking this patient, or the primary care provider may be asking, you know, a patient about their own drug use or alcohol use, and the patient maybe is not using alcohol or drugs in an unhealthy way, but their family members are. And so there have been times where that then prompts a conversation with that patient about how to offer help to that family member, offering Narcan to that patient so that they, or the Narcan, the community Narcan training that we have to that patient, so that then they have that resource available for their family member. You know, talking about treatment options, talking about the family patterns that contribute to addiction. And so, you know, we talk about enabling behaviors and things that get in the way of somebody deciding that it's time to make some changes. So that was something that I think we hadn't really expected. So it was really encouraging to see. As I mentioned, the SBIRT Oregon website has some great resources there. So it's got role plays, training videos, a whole training curriculum. They have pocket cards that you can order and laminated like color sheets that you can, well, they're not laminated, you can laminate them, but color sheets that you can print that are patient education material, provider education material, just a wealth of resources on their website. The SAMHSA SBIRT website also has some great resources. And again, I mentioned billing and coding guidance, which is really helpful as you start to look at financial sustainability and the impact of this. We know it's best for patient care, but we also have to figure out a way to pay for it. And so they've got some guidance on that as well. From there, I think that is all that I have. So if there are any questions, I'm happy to answer whatever I can.
I have a question for you, Laura.
Awesome.
Is there a spot for SBIRT outside of a clinical setting?
Yes. So there's some, well, so to billing it would be different outside of a clinical setting. But I think you could use it in lots of settings. I mean, there's some evidence out there about the use on college campuses, and whether that's through their healthcare setting or whether it's through just other standardized kind of new student information. I think that that's an excellent way to do it. And I think about that. We do a lot of work with Berea College, and the college student population is one that has got a lot of misconceptions about what's healthy and unhealthy. And so I think that, in the, like, when new students are coming in, if there's an opportunity to kind of do some of the standardized universal education work, could be really helpful. I think schools have a great opportunity to do it. It gets tricky with kids because of the consent piece of it, and because of the parent piece of it, and because of the resource piece of it, but it doesn't mean we shouldn't be doing it. So I think that there certainly are other community settings where it could be really helpful.
Thank you so much. So you screen every patient that comes through Whitehouse, or you offer the screening to every patient that comes through Whitehouse?
Yeah, right now we're offering it to adults. So every patient 18 and older who comes through, we offer the screening once annually or rescreen as needed. We know that we need to work out a workflow for adolescents. There are a lot of, just like I mentioned, a lot of complications. One big complication being that if they need treatment, where are they going to go? So, it's hard to, find all this information and then have nowhere that is local that they can get a higher level of treatment. So, but we're in the process of working out the process, how we would address this with the adolescent population as well.
Awesome. That's great. So you mentioned that the process that Whitehouse Clinic went through, but do you have any tips for other small rural healthcare providers in implementing SBIRT or getting that into their work?
Yeah, I would say that, like, especially if you're a smaller clinic. So when we do things here, because we are large, it's a lot of process. But I feel like any medical provider could decide that they were just going to do this with their patients. You're just asking the question the same way that you ask questions about other behaviors. And so, you would just, depending on the EHR, depending on the documentation, there are different ways that you could do it, certainly. But I think that it doesn't have to be quite so complicated. But I would say know what your resources are and what resources you have in your community